three variables بتحكموا فيه: البريلود، الكاردياك اوتبوت، عفوا البريلود والافترلود والاينوتروبي او الكونتراكتيليتي. فلما تثبت واحد يعني either you modify الاينوتروبي او الافترلود في حالة تثبيت البريلود زي ما هو بهذا الجراف. هلا يعني when we treat patients نعطيهم preload reduction using diuretics أو vasodilators، نحن عم نحسن basically cardiac output by decreasing the afterload. فالvenodilators والdiuretics are preload reducers، بس vasodilators are afterload reducers. والinotropic agents زي الدوبيتامين بيزيدوا الcontractility. So the goal here is to increase the cardiac output. We play around with the variables اللي حكيناهم الثلاثة. أشياء بتقلل البريلود، أشياء بتقلل الأفترلود، أشياء بتزيد الcontractility. So that's the idea of this graph. لما نطلع على pressure volume loops، pressure volume loop هلا if you start from D، هون الميترال فالف بيفتح، فهون الفنتريكل بيصير يعبي عند 50 يعني تقريبا الاند دايستوليك الدايستوليك فوليوم عند الاوبننج تبع الميترال فالف. at end diastole لما يخلص الميترال فالف الاوبننج تبعه وبده يسكر عند تقريبا 125 the mitral valve closes، وبالتالي بيصير بعديها isovolemic contraction، يعني الفوليوم ثابت بس البريشر بيعلى، فبنتقل من A ل B الفوليوم نفسه بس البريشر عالي. Once the pressure inside the ventricle is high enough to open the aortic valve، الايورتيك valve بيفتح عند B وبصير الايجكشن of the blood من B ل C. وصلنا لعند C خلص السيستولي بيسكر الايورتيك valve، بس سكر الايورتيك valve بصير عندي مرحله نسميها الايزوفوليميك ريلاكسيشن، بمعنى البريشر بنزل بس الفوليوم ثابت، بس نزل البريشر انف برجع بفتح الميترال فالف اند سو اون. من هاي الجراف اللي قدامكم البريشر فوليوم لوب جراف نقدر نحسب الايجكشن فراكشن اللي هو الاند دايستوليك ماينس الاند سيستوليك على الاند دايستوليك فوليوم، فهذا بيعطيني الايجكشن فراكشن. فلو فرضنا مثلا 125 ناقص 50 هي 75 مقسومه على 125، فبيطلع تقريبا الايجكشن فراكشن نفرض انه 60-70%. فمن هنا اجى الايجكشن فراكشن. Now the patients with heart failure في عندنا initial compensatory mechanism for impaired myocyte contractility. واحدة الفرانك ستارلينج mechanism، الثانية neurohormonal activation، والثالثة increase intravascular volume. يعني لما ينزل الكاردياك output due to myocyte weakness و decrease cardiac output بيصير في عندي activation of the renin system زي ما راح نشرح بعد شوي، وهذا بيؤدي للانجيوتنسين cascade والproduction of aldosterone و increase in the intravascular volume. هلا eventual decompensation هذا البداية. eventual decompensation happens due to ventricular remodeling, myocyte apoptosis و valvular regurg due to the extreme dilatation of the ventricle with time. The three major players بالheart failure الRAS system اللي هو renin angiotensin aldosterone system، الsympathetic nervous system، والnatriuretic peptide system. those on your right الRAS والSNS هذول bad players، والNPS هو good player، مشان هيك هو in green وهدلاك in red. The RAS system زي ما انتم عارفين بيؤدي ل activation of angiotensin 2 which has very bad effects on the vascular bed و absorption of salt and water, و activation of the aldosterone which does the same and does the apoptotic part of heart failure, while the SNS is the increase in the sympathetic overdrive which leads to activation of the beta receptors, and that has also a major role in the fibrosis and the remodeling in heart failure patients. The natriuretic peptide system antagonizes this effect by vasodilatation, decreasing fibrosis and natriuresis. and we'll come into details to these three mechanisms. The pathophysiology is adrenergic nervous system اللي هو ال SNS, renin-angiotensin system, and natriuretic peptides. Beta receptor density in patients with heart failure is increased, and that has to do with the excessive stimulation of the sympathetic system. This is the المفروض تكون معروفة لكم هاي الجراف اللي بتفرجي كيف الاكتيفيشن of angiotensinogen من الليفر هو produced in the liver بوجود الرينين يعني gets to be activated due to low cardiac output. بيطلع من الجكستاجلوميرولار سيلز بالكدنيز، فبيرتفع الرينين بيحول الانجيوتنسينوجين من الليفر لانجيوتنسين 1 و1 ل 2 باللونجز using الACE enzyme، والانجيوتنسين 2 using ال AT1 receptor بيؤدي للالدوستيرون برودكشن. وهذا بفرجينا الاماكن يعني الفارماكوثيرابي كيف عملت انتربشن للمناطق اللي فيها هاي الكيميكالز. فبنلاحظ الايس انهبيتورز تشتغل على الايس انزيم، والسبيرونولاكتون بيعمل بلوك للالدوستيرون، والانجيوتنسين ريسبتور بلوكرز كيف بيعملوا بلوك لل AT1 ريسبتور حتى ما يصير برودكشن اوف الدوستيرون ويبطلوا شغل الانجيوتنسين 2. Angiotensin 2 حكينا لكم هو very bad player، فالباد effects تبعته من vasoconstriction، aldosterone production، myocyte hypertrophy، fibroblast proliferation اللي بيؤدي للfibrosis، collagen deposition، apoptosis، prothrombotic، pro-oxidant, and so on. So angiotensin 2 is the key chemical leading to the geometric changes in the left ventricle and leading to the clinical heart failure in our patients يعني when they present, and that's why it's considered the main target in our therapies using ACE inhibitors, ARBs, and recently ARNI, angiotensin receptor neprilysin inhibitor. Now, when we look at the natriuretic peptide, حكينا الeffects تبعته antagonizes الباد effects تبع ال SNS وتبعت الراس system. فبنلاحظ على النيرفس سيستم بيعمل SNS inhibition, lowering of vagal afferent activation. Vascular system بيعمل vasodilatation وhypotensive effect وangiogenic effect. على الهارت cardiac load reduction, decrease in the hypertrophy inhibition and fibrosis inhibition. On the kidneys بيعمل sodium release, water release, natriuresis, RAS inhibition, and increase in GFR. The kidneys and the heart, due to the reduction in cardiac output, حكينا بيصير في عنا reduction in the renal blood flow that leads to lowering of the GFR, production of renin, increased sodium tubular reabsorption, and by so free water retention through vasopressin لأنه بس زادت الأوزمولاليتي الvasopressin release بيصير. Now, if a patient suffers from an event سواء ischemic event أو myocarditis, whatever it is, بيكون الهارت طبيعيا هو elliptical in shape, ellipsoid يعني أو ellipse like in shape يعني زي طابة كرة القدم الأمريكية إذا تتخيلها. With time, patients go into remodeling due to the fibrosis and the apoptosis process. بتغير المورفولوجي تبع الليفت فنتريكل بصير spherical in shape، وهذا بيؤدي ل change orientation of the papillary muscles و dilatation of the annuli تبع الميترال وتبع الترايكاسبيد، فبيؤدي ل significant regurgitation. Change in geometry, dilatation of the ventricle, and severe regurgitation of the mitral and tricuspid valve are consequences of what you are seeing من geometric change اللي بصير بالventricles. The clinical findings طبعا هي explained by drop in the stroke volume cardiac output، تخلي المريض fatigued و weak. حكينا عن موضوع dilatation والmitral regurgitation بسبب المريض dyspneic. increase in ventricular filling pressures وبالتالي بيؤدي للأعراض اللي بنعرفها الأورثوبنيا PNDs and the congestive symptoms where edema, ascites and elevation in JVP are seen. On examination, if you examine a patient with heart failure بيكون tachycardic, hypotensive, low pulse pressure, full extremities, pulsus alternans. على اللونج اكزام تسمع crackles او rails وpleural effusions احيانا. الكاردياك اكزام بيكون laterally displaced apex beat و S3 و mitral regurg murmur. بالcongestion نشوف ال JVP elevated, hepatosplenomegaly, ascites and peripheral edema. The diagnostic tests that we use to diagnose our patients are chest X-ray, where you see cardiomegaly. مرات بتشوف interstitial edema. بتشوف بتشوف interstitial edema. بتشوف pleural effusions على X-ray. All of that can be seen on X-ray. The ECG حسب الetiology. But generally, it's a must to do an ECG to understand if there are arrhythmias related to the heart failure, if there is any ischemic changes, STT wave changes related to this. So really, the ECG can help you in different ways, although it can be normal. So. The preference طبعا انه to perform echocardiography to know if you have systolic or diastolic dysfunction, to do blood test, particularly kidney function, to do BMP, which we will come to, and other tests that may give you the diagnosis of why the patient has heart failure. Coronary angiography and hemodynamics in the cath lab, and finally consideration of endomyocardial biopsy. Why are we concerned about this? Because ejection fraction is associated with poor prognosis in our patients. So a normal EF survival compared to a reduced ejection fraction survival over years. So you notice how significant this is. Heart failure is a major and growing public health problem. يعني despite the medical advances من ناحية أدوية, من ناحية catheterization, من ناحية everything around, بتقول oh we should have control over this disease, but in reality no. Now how common is this problem? When we hit the age of 65-70, it's around 20%. So it's really common. So lifetime risk is about 20%. هلا كpopulation it's around 2%. The expenses are very high, especially inpatient. Why is heart failure is growing? Because there is increased prevalence of risk factors. Patients are aging, يعني living longer, and the improved post-MI survival with the advancement in thrombolytics and catheterization, patients survive myocardial infarction more than before. And this is the budget. If you look at inpatient treatment, it's about 70% cost and 10% to the outpatient therapy, despite the expenses تبعها. What is the prognosis? Prognosis is quite bad. Really, the heart failure patient over years, يعني هون نحكي عن 5 years, 60 months. بتلاحظ إنه it comes second to lung cancer in both males and females. In both males and females, lung cancer carry the worst prognosis. يعني هو بيجي next. بعدين بحالة الفيميلز ovarian, bowel, MI, breast. بحالة الميلز heart failure followed by colon, followed by prostate, bladder, and myocardial infarction. It is still associated with significant mortality. If you look at time from hospitalization, at 30 days, 1 month, 10% mortality, at 1 year, 20%, and at 5 years, nearly 40 to 50%. It's a progressive condition with high morbidity mortality. If you look here, the dips that you see and the rises that you see are related to recurrent hospitalization or ER visits. And with every hospitalization ER visit, you are dealing with يعني increased risk of mortality and morbidity. لأن المريض بيجيك بيكون نفسه تعبان، ممكن يصير معه respiratory arrest، بنحط على ventilator أو بنحط على positive pressure ventilation, and he may come off that device or he may not. Add to that, he may be in hemodynamic compromise, hypotensive, requiring vasopressors. So these are sick patients. أحيانا بيكون basically in cardiogenic shock. So the scenarios are different, but with every admission, we are increasing the likelihood of mortality. So the mortality increases with every admission. Heart failure has a number of common causes. The most common cause اللي in orange هنا بهذا السلايد هو الكوروناري ارت ديزيز، compromise تقريبا 70% من مسببات الهارت failure. The others are related to valvular heart disease, to cardiomyopathy, which could be idiopathic, or others like myocarditis or alcohol, or the causes are varied, and we will discuss cardiomyopathies on a separate lecture. So here you see these patients with multiple comorbidities, patients who are basically diastolic heart failure are usually elderly, female are predominant, obese, they are diabetic hypertensive patients that we find diastolic dysfunction and heart failure more common. For systolic heart failure, usually males, usually younger age group, but they may have the risk factors that lead to this coronary event, including diabetes, dyslipidemia, hypertension. Smoking in our country and in the region is a major risk factor. So systolic and diastolic heart failure, they present the same, so you cannot really differentiate in the majority of time between the two, just clinically. So you have to perform the echo to know more information, and the profile of the patients may help you. So a young man with a history of myocardial infarction, this is likely systolic dysfunction due to the myocardial infarction, while an elderly female with a preserved ejection fraction who presents with heart failure is likely a diastolic dysfunction. تعلمتوا انتوا بجوز الليفل اوف ايفيدنس والكلاس اوف ريكومنديشن. سو لما نحكي احنا كلاس 1 ريكومنديشن يعني this is a definite benefit. Class 3 recommendation is a definite no benefit or harmful. Class 2A probably beneficial, 2B possibly beneficial. Level of evidence إذا بنحكي مثلا class 1A, A means إنه based على multiple randomized trials, B على single randomized trial, and C is just a consensus where experts in the field decide that this is the class of recommendation. So ممكن أحكي لك إنه الأسبرين is a class 1C. ليش؟ لأنه الأسبرين you cannot study in a randomized pattern إنه تعطي مريض MI تقول له أعطيك أسبرين أو placebo. This is unethical. So some guidelines يعني C مش معناته إنه weak evidence. It's rather sometimes not possible to perform studies. So what is heart failure? إذا بتنسأل هذا السؤال. Heart failure based على ال guideline recommendation هو clinical syndrome where patients have typical signs and symptoms resulting from a structural or a functional impairment of the heart to eject blood. So it is a syndrome of signs and symptoms due to a structural or a functional problem of the ventricle to eject blood. The symptoms, you already know them: shortness of breath, orthopneas, PNDs, lower limb edema, and reduced exercise tolerance. The signs: elevated JVP, hepatojugular reflex, third heart sound, cardiac murmurs, and so on. So what is the definition of basically when we say, let's look at the green, and this green stands in 2013 and as of today. So heart failure with reduced ejection fraction is defined as an ejection fraction of 40 or less. Heart failure with preserved ejection fraction, HFpEF, is defined as heart failure with an ejection fraction of 50 or more. Those between 41 and 49 as called mildly reduced heart failure patients. Those who have an improvement in their ejection fraction of 10% or more to reach 40% or more are called heart failure with improved ejection fraction. So these are the different definitions of HFrEF, HFpEF, MRHF, and the improved ejection fraction. When we look at the patients, this cartoon is just showing you a normal heart, a patient with diastolic heart failure or HFpEF, and a patient with systolic heart failure, a HFrEF case. The HFpEF case, preserved ejection fraction, that is, they have no left ventricular dilatation. It's mainly a concentric remodeling hypertrophy. So the thickness of the ventricle is more than normal. And you have diastolic dysfunction by other parameters, like the left atrium will be dilated. If I do a mitral inflow Doppler study by echo, I will see it abnormal. If I do tissue Doppler imaging, I will see the tissue Doppler abnormal. So there are echo criteria beyond the scope of this lecture to diagnose patients with heart failure and preserved ejection fraction. So diastology is abnormal, and that's why we diagnose these patients despite a normal ejection fraction as heart failure with preserved ejection fraction. Now, for patients with HFrEF, it's a bit easier to diagnose. Why? Because you see the contractility impaired and the ejection fraction is low. The ventricle is dilated and thinned out. Now, if you look at the classification of function, which you know already, the New York Heart classification, patients who have no limitation of their physical activity, they are given class 1. Those who have slight limitation of their physical activity, they are given class 2. Those with marked limitation of their physical activity, 3. And 4, those with heart failure at rest. Now, the staging of heart failure depends on, again, is described here based on A being a patient who is not having any heart condition. He's just having risk factors like a diabetic hypertensive patient. While B, stage B, is a patient who have a structural problem. For example, the ejection fraction of someone I saw in the clinic today is 30%. Has he ever had heart failure presentation? Never. Is he now in heart failure? No. So it's B is a structural heart failure problem, but without signs or symptoms of heart failure. So to have a low ejection fraction does not mean that you have heart failure. It means that you have stage B myopathy. You haven't presented with heart failure yet. Stage C are the majority of our patients. Stage C are patients who have history of or currently in heart failure with a structural problem like B. يعني ejection fraction is low في حالة الHFrEF. Stage D, those patients have refractory heart failure and require advanced therapies like transplantation or left ventricular assist devices. Now, when we look at our patients, we find them in one of the 4 quadrants. The best quadrant to be in is warm and dry. Warm refers to good perfusion. Their blood pressure is well, their cardiac output is good, so they're warm. And they are dry. They are not overloaded. Their preload is within range. They are not congested. If you go to the extreme, where patient is cool and wet, where the patient is hypotensive, shocky, and also congested. Those are very challenging to manage. So the 4 quadrants: warm and dry, warm and wet, cold and dry, cold and wet. So patients can be in any of these 4 groups. Again, patients who we are talking about are those with congestive heart failure, usually combination of these left-sided and right-sided failure. Our patients have right-sided heart failure due to the left-sided heart failure. Very uncommon to see a pure right-sided heart failure due to an underlying pulmonary disorder, which we call cor pulmonale, isolated right-sided heart failure. So the 99% of the cases that we deal with are the ones who have left-sided heart failure associated with right-sided heart failure. The presentation, as mentioned before, is shown in this cartoon to describe how patients with left-sided/right-sided heart failure present. You see lower limb edema, you see weight gain, elevation in JVP. On the left, there is a heart failure X-ray. On the right, it's a normal X-ray. For investigation, we have already briefly touched on them. An ECG is an important parameter to know if you have any underlying conduction problem, arrhythmias, ischemic heart disease, and so on. A chest X-ray, we have discussed it, echocardiography, biochemical and hematological, looking for kidney function and the natriuretic peptides. Now, the natriuretic peptide is a 32 amino acid. This basically is released, although it's called the brain natriuretic peptide, it's released from the myocytes in the ventricles. طبعا ده في ANP اللي هو الاتريال وفي CMP تاع التشيو. بس BMP هو المين one that we use, and we use it for diagnosis. So the BMP is basically produced from pre-pro-BMP, and that is transferred to a pro-BMP. Pro-BMP is cleaved into BMP and the N-terminal pro-BMP. NT-pro-BMP is inactive. BMP is the one that causes the good effects that we have discussed, the vasodilatation and so on. The NT-pro-BMP, both of them are available as kits for testing. يعني احنا نفحص مريضنا بالNT-pro-BMP أو بالBMP. The more accurate هو NT-pro-BMP. The reason for its accuracy لأنه الهاف لايف زي ما أنتم شايفين تقريبا ساعتين، بينما BMP only 18 minutes. So it's more stable when you draw blood. Second, الثيرابي اللي راح تشوفوها بعد شوية للهارت فيلير تتداخل مع التستنج هذا. يعني الارني الانجيوتنسين ريسبتور نيكليسرين انهبيتور هو نفسه الدواء بيؤدي لرفع البي ام بي. فبصير كونفيوزنج انا هل هذا المريض لانه ماشي على الدواء البي ام بي عنده عالي، ولا هل هو عالي لانه عنده هارت فيلير. سو بيسكلي اللي عم نحكيه هنا البي ام بي والان تي برو بي ام بي ار تيست فور هارت فيلير. يعني بيجيني مريض انا نفسه تعبان، هذا المريض انا ما عم بعرف بيست على كلينيكال هل هو سي او بي دي ولا هل هو سي او بي دي اكسسربيشن ولا هل هو هارت فيلير. بعمل له هذا التست. اذا كان high then this goes with heart failure. إذا كان low then this does not go with heart failure. So it has high specificity, high sensitivity, good predictive value on either end, the positive and negative predictive values. Now حكينا عن البرزنتيشن، هلا بنحكي عن الأدوية، وهذه السلايد ما فيها كل الأدوية، راح نحكي عن more medications. So when we talk about ACE inhibitors we have talked that they work on angiotensin 1 ل 2 بيعملوا inhibition على ACE enzyme، وهذولا basically الريسكس تبعهم زي أي anti-hypertensive medication, hypotension, but they can lead to hyperkalemia and acute kidney injury, and cough can be a reason to switch from ACEs to ARBs, as you know, and this happens due to bradykinin accumulation. Now for ARBs, they work on the AT1 receptor. So they block the action of angiotensin 2, and that's what we need, is to block the action of angiotensin 2. The beta blockers are used to block the sympathetic nervous system. والبeta blockers طبعا wide group of medications and with side effects that are listed here. MRAs اللي هو المينراليو كورتيكويد receptor antagonist هذول اللي هم السبيرونولاكتون which blocks the aldosterone, and these medications, they inhibit the binding of aldosterone to its receptor. They are adjunctive therapy in patients with heart failure to ACEs and beta blockers. مثال عليهم هو الإليبرينون والسبيرونولاكتون. And you should start low and increase your dose gradually. الترايلز الريلز والemphasis هذول ما لكاش فيهم كأسماء trials. So the side effects that can be seen with spironolactone are related to hyperkalemia. They can lead to acute kidney injury, and you should withhold them إذا المريض عنده elevation بالcreatinine أو بالpotassium. In addition, spironolactone is associated with gynecomastia, which you don't see with eliprinone. Diuretics, طبيعي diuretics أنواع مختلفة، ولكن احنا بهمونا هنا أكثر loop diuretics اللي هو الفيوريساميد bumetanide more than hydrochlorothiazide. The thiazides can be used in combination with loop diuretics, but generally the loop diuretics are the mainstay therapy of patients with heart failure because they unload يعني بيخففوا البريلود وبالتالي بيحسنوا البريذنج للمرضى والفluid accumulation generally in ascites and lower limb edema. So although they are not listed as drug-saving medications because they are not studied in randomized fashion, but they are life-saving medication that you cannot afford to withhold these drugs from patients who present with acute heart failure على emergency room with long-term therapy. So they are the mainstay drugs to keep the patients nearly euvolemic. Ivabradine is a relatively new drug. It's a drug that works on the F channels and the SA node. Basically, the F channels lead to bradycardia. So patients who are on beta blockers and not achieving a reasonable heart rate, patients who have contraindications for beta blockers, where I need to bring their heart rate down to 60 to 70, where I like it in patients with heart failure. Ivabradine is the medication to go to. So it is an SA nodal blocking agent. It is not used in other arrhythmia, يعني sinus tachycardia okay, أو حتى لو sinus وبدي أنزل heart rate okay, but not in AFib, not in SVT. So the only approval is for sinus rhythm. It is a selective sinus nodal agent. It's rapid and completely absorbed after oral administration. There are minimal side effects, if any. One of them is related to visual side effect, which is transient. Indications other than heart failure is angina. Digoxin, you're aware of digoxin. It's a cardiac glycoside. Basically, it's used as an add-on therapy to patients with heart failure for symptom relief. There is no survival benefit of digoxin. Occasionally, we use it in patients with atrial fibrillation to control their rate. So the drug is used for both indications, for heart failure, for decreased hospitalization and improving symptoms in patients who have still symptoms despite the maximum medical therapy. The other indication is for atrial fibrillation for rate control. The problem with digoxin is its therapeutic index is narrow, so the toxicity is high. And although the doses has been recommended to be lowered, despite lowering the doses, digoxin still carries a high risk of toxicity. And one of the major organs is the heart. it leads to different brady and tachyarrhythmias. It leads to GI disturbances and neurological disturbances like depression. The combination of hydralazine nitrates has been studied in one trial, the AHEFT trial in African American population. And in that population, it was an add-on therapy to ACEs, beta, and aldactone. In that patient subgroup, which were the African Americans, it showed survival benefit. So the combination is approved to be used in that race. But the use in other races is basically an extrapolation of the data to be used in other races. بمعنى ما في عندنا evidence, but is it still being used in other races? Yes. So when we look at the huge literature that we have on the different agents, we see 16% improved survival with ACEs, ARBs nearly the same, beta blockers 34%, and when we look at the MRAs, 30%. How about the new agents? ARNI is replacing ACEs and ARBs. ARNI is angiotensin receptor neprisilin inhibitor. What is neprisilin? Neprisilin is the enzyme that degrades BMP. So BMP in the serum is high in heart failure patients. The neprisilin degrades that BMP بحطمه. فاحنا هدفنا هون نحافظ عليه لانه ماده مهمه. فبنعطي الساكيوبيتريل. ساكيوبيتريل بيعمل انهبيشن للنبرسلين فبيعمل accumulation للBMP. At the same time, the sacubitril leads to basically stimulation of angiotensin 2. So we combine valsartan, which is an ARB, with sacubitril. فالagent صار اسمه ARNI أو انترستو عفوا ضمن جروب الARNI. فإذا مرق عليكم هالاسم انترستو هو combination of sacubitril and valsartan. So it works on both enhancing the effect. تتذكروا الثري main mechanisms. حكينا natriuretic peptides, حكينا SNS, حكينا الRAS. So هذا بيشتغل على ثنتين، بيعمل stimulation أو تحفيز للnatriuretic peptide pathway وبيثبط الRAS pathway. So it works on the two. How about SGLT2 inhibitors? هذول sodium glucose transport 2 inhibitors. هذول موجودين بالproximal tubules. أصل الحكاية إنهم هذول diabetic medications بيعملوا glucosuria وبالتالي بيحسنوا diabetic control. Well, they were found in diabetics and non-diabetics that these agents improve heart failure and improve survival in heart failure patients. So not only symptoms because they cause diuresis, but they rather improve the ejection fraction and ends up with improved mortality in patients with heart failure. So now when we look at the class of recommendation for these agents, نطلع على class 1A, multiple randomized trials. مزبوط؟ Class 1A definite benefit. ARNI/ACE/ARBs. They take 1A recommendation. Beta blockers, class 1A recommendation. Lasix, loop, شايفين ماخذ 1C. ليش؟ لأنه ما بقدر أعمل له randomization وأسوي studies. But it is life-saving. It's class 1C recommendation. Now, when we look at ARBs, ARBs are also class 1A, but when there is a contraindication to use ACE inhibitors, يعني مريض عنده cough بعطيه ACE. MRAs are also class 1A indication. So now we have يعني basically 4 pillars of therapy. 4 pillars. شو هم ال4 pillars? Pillar number 1, ARNI/ACE/ARB. هاي واحد. Pillar number 2, beta blocker. Pillar number 3 هو ال MRAs. وpillar number 4 هو ال SGLT2 زي ما راح تشوفوا هلا. الديجوكسين هو class 2A. probable benefit. وحكينا متى بنستخدم الديجوكسين. حكينا إذا المريض عنده heart failure despite maximum medical therapy I use digoxin. والهدف من استعماله مش to improve survival، هدف من استعماله to improve morbidity، يعني أخفف الhospitalization. Hydralazine nitrates are used as a class 1A in African American population because that's the race where they were studied. But the data is extrapolated to be used in other races. But again, ما فيش عليها evidence. So they are used as class 1A in that race. Ivabradine بالAmericans ما عندنا عليهم data, but بالEuropeans they are used. And again, their use is in angina and heart failure patients, those who do not achieve the target heart rate. When we look at the recommendations, حكينا عنهم ACEs, beta blockers, حكينا عن SGLT2, حكينا عن ARNI inhibitors. مزبوط. So these are basically the different drugs that are approved nowadays for heart failure patients. حكينا عن الستيجينج، قلنا ستيج 1 هذول المرضى اللي ما عندهم مرض بس عندهم ريسك فاكتورز. سو مريض عنده هايبرتنشن بعطيه ايس او ارب، مريض عنده دايابيتس بعالجه and so on. ستيج بي لا، بدي اعطيه لانه هذا عنده لو ايجكشن فراكشن، ما صار معه هارت فيلير لسه، بس انا do I have to give him Lasix مثلا لهذا المريض؟ الانسر is no، لانه he's not overloaded اصلا. فانا مثلا ممكن اعطيه ارني ايس اور ارب، طبعا بدك تعطي واحد منهم مش هيك. بيتا بلوكرز، هلا الام ار ايز are not approved for those with New York Heart Class 1 which this group is، يعني هذول ما عندهم symptoms at all، فانا ما بقدر اعطيهم ام ار ايز. هذولاك they are made for Class 2 to 4. فهون انا المسموح لي اعطيه هي الايس سلاش ارب سلاش ارني. A beta blocker can be used, an SGLT2 can be used. بس في نويز عم يطلع من حدا منكم، بس لو تسكروا لنا المايك. Stage C are the bulk of our patients, and this group of patients اللي حكينا عندهم New York Heart Class 2, Class 3, Class 4. إذا Stage C. Stage D هي الادvanced اللي requiring mechanical devices. Again, this is pretty much talking about medical therapy. You read this slide at your convenience. Now, when we look at patients with heart failure, they occasionally have left bundle branch block on ECG. And what that means is basically that the septum has electricity before the lateral wall. And that's why the left bundle happens. يعني left bundle إذا تتخيل أنت البندل of His بنقسم ل right to left bundle. الليفت bundle بنقسم ل left anterior fascicle و left posterior fascicle. If you have a block in the left bundle conduction راح توصل الكهرباء للرايت bundle أسرع، وبعدين gets to be transmitted through the ventricular myocytes into the left. The contractility in the septum is earlier than the contractility in the lateral wall, and that causes dyssynchrony. بمعنى ال ventricle contracts at two stages، واحدة على السبتم خلالها بيكون اللاترال وول ريلاكس، وبعدين اللاترال وول والسبتم بتكون ريلاكس، فهذا بيعمل شيء بنسميه dyssynchrony. Now, just to continue my thought, the CRT, which is a resynchronization therapy, basically is a device that's used to make the electricity reach both the septum and the lateral wall at the same time. So you resynchronize the heart to contract properly. ما هو ICD? ICD is an intracardiac defibrillator. هذا يزرع عند الناس اللي عندها heart failure as a safety box، يعني ممكن ما يستعمله بس ممكن يستعمله. هلا شو هو هذا؟ هو زي البادلز اللي بتشوفها when we shock patients، بس هاي الديفايس هي صاعق داخلي، يعني يزرع بالهارت. It detects the malignant arrhythmias it delivers shock. So basically what the scenario هنا is إنه إذا كان ejection fraction أقل من 35%, you have an indication to insert a device which is an ICD. أما بالنسبة للCRT، الCRT هي device تزرع عند الناس اللي عندها heart failure و still very symptomatic على maximum medical therapy وعندهم على ECG left bundle branch block. So ممكن يستفيدوا من الCRT. I hope it's clear. Basically هدول indications وهذول basically نيويورك heart class 2 to 4 with left bundle. It improves their exercise tolerance, reduces symptoms, it reduces mortality even, reduces remodeling, and reduces the rate of hospitalization. I hope you enjoy the lecture. لمن حضروا، ما بعرف كم واحد حضر. $109 not bad. اوكي، اي سؤال؟ إذا ما في أسئلة، الله يعطيكم العافية. لقاءنا إن شاء الله الأحد على الساعة 4 إذا الله بريد. سلامات. Enjoy the weekend.